It's a mysterious topic, right? Dear Chair, thank you very much indeed for your kind introduction. I don't know how found this topic, but it was worth it. We usually consider genetics, lifestyle, and environment as the primary determinants of the health. However, a growing body of evidence clearly shows that a substantial amount of our metabolic destiny is programmed even before the birth, during intrauterine life. Today, I will focus on how gestational diabetes shapes this early programming and its impact on the long-term metabolic health. As understood from the concept of gestational diabetes, pregnancy is a physiological process that predisposes individuals to diabetes. So what makes pregnancy prone to diabetes? Two key factors play a crucial role in the development of gestational diabetes. Number one, maternal hormonal and metabolic changes. Number two, maternal immune dysregulation. As you all know, the main source of energy for the fetus is glucose, and the fetus draws this glucose from the mother through the placenta, creating 10 to 20 milligram glucose gradient. And interestingly, the fetal glucose consumption extremely high, approximately 5 to 10 times higher per kilo than mother's glucose disposal. This extremely high fetal glucose consumption is ensured and maintained a series of maternal hormonal and metabolic changes. These maternal hormonal and metabolic changes bring about insulin resistance, particularly at the end of the second trimester, because of increased placental lactogen, increased progesterone, cortisol, as well as prolactin concentration. Additionally, maternal immune dysregulation also play a critical role in the development of GDM. During the pregnancy, paradoxically, adaptive immune system consists of T and B lymphocytes is suppressed, particularly at the fetal-placental interface. On the other hand, we see overactivation of innate immunity composed of macrophages, neutrophils, and monocytes. As a result of increased innate immunity, pro-inflammatory cytokines, which are produced by innate immune cells, such as TNF-alpha, interleukin-6, and interleukin-1 increase. On the other hand, anti-inflammatory cytokines, adiponectin and interleukin-10 decrease. Consequently, the delicate balance between the pro-inflammatory cytokines and anti-inflammatory cytokines are seriously disrupted in favor of pro-inflammatory cytokines. It leads to further insulin resistance because TNF-alpha impairs insulin signaling by affecting IRS1 phosphorylation, and interleukin-6 disrupt glucose transporter for production and translocation to the cellular membrane. All leads to insulin resistance. Now, altogether, coexisting in the one hand, maternal hormonal and metabolic changes, in the other hand, maternal immune dysregulation cause severe insulin resistance. It peaks in the late trimester, in the third trimester. As you can see in this figure, insulin sensitivity decreases roughly by 60–65% compared to pre-pregnancy period. Can you understand how serious this insulin resistance is? Exactly the same is seen in type 2 diabetes. Exactly the same. From this perspective, gestational insulin resistance is literally a challenge for the beta cell. If beta cell reserve is able to compensatory insulin response to overcome this maximum insulin resistance, then pregnancy continues normally. Otherwise, if beta cell reserve is insufficient to compensatory insulin response to overcome this insulin resistance, then pregnancy is complicated by diabetes and glucose intolerance develops, called gestational diabetes. Many years, gestational diabetes as defined as a glucose intolerance with onset or first recognition during the pregnancy. However, recently, this traditional definition was changed by the ADA. According to the new ADA definitions, GDM diagnosed in second or third trimester, because it clearly excludes the first trimester diagnosis, because unlikely undiagnosed type 2 diabetes. To fully understand the clinical consequences of gestational diabetes, it is essential to grasp the extent and mechanisms of placental nutrient transport. Let's take a closer look at the placental nutrient transfer. Placenta is a key player in maternal fetal supply chain. It provides oxygen, it provides macro and micronutrients which are essential for fetal development. As a main source of energy, glucose can easily cross the placenta to reach the fetus. Amino acid also can easily cross the placenta. However, transportation of lipids are limited. Only less than 3% of free fatty acid can cross the placenta. The transportation of glucose is mainly facilitated by a protein called glucose transporter 1. And as you can see here, glucose transporter 1 saturation threshold of placenta is extremely high, approximately 25 millimole. It means glucose can easily cross the placenta, creating 10 to 20 milligram glucose gradient between the mother and fetus, until mother's glucose concentration reaches 450 or 500 milligram. It's undoubtedly one of the biggest problems for the fetus exposed to high glucose concentration. Fortunately, we don't see this high level in gestational diabetes, but we see this high level in pregestational diabetes. If we look at the fetal side, fetal beta cell maturation is completed around 12 weeks of gestation at the end of the first trimester. If fetal beta cell exposed to high glucose concentration after this point, it produces more amount of insulin. And more amount of insulin leads to fetal hyperinsulinemia. Pay attention, please. Fetal hyperinsulinemia plays a pivotal role in both perinatal adverse outcome and long-term metabolic risk faced by the offspring, because fetal insulin binds to IGF-1 receptor with equal affinity to insulin receptors. And growth factors such as insulin, not growth hormone, are key promoters of fetal growth. It promotes lipogenesis, it increases lipid accumulation and accelerates fetal growth and leads to macrosomia. And additionally, the critical point, exposure, high and prolonged hyperinsulinemia during the intrauterine life may also pave the way for insulin resistance in later life. This is the landmark trial called PIMA Indian Sibling Study. It was published in Diabetes Journal in 2000. This study clearly and convincingly demonstrated that intrauterine exposure to diabetes conveys risk for type 2 diabetes and obesity. In this study, siblings born after gestational diabetes exposure show markedly higher diabetes, obesity, and cardiovascular risk compared with their brothers born before gestational diabetes. They are the same mother. And I want to show their impact on the offspring. This figure illustrates the prevalence of diabetes in the offspring of non-diabetic women, as shown as open bars, and offspring of diabetic women, as shown as solid bars. Look at the age 2024. The prevalence of diabetes in the offspring of non-diabetic women, approximately just a few percent, less than 5%. How about the prevalence of diabetes in the offspring of diabetic women? Approximately 40%. And look at the age 25 to 29. The prevalence of diabetes in offspring of non-diabetic women, just 10%. And look at the prevalence of diabetes in offspring of diabetic women, 80%. It's 8 times higher the risk. They are siblings. Regarding the genetic basis, the same genetic basis because of the same mother and same father. What's the difference? Difference is only intrauterine environment. And by the age of 30, only 20% of offspring remain non-diabetic in the offspring of women with GDM. These statistics is truly astonishing. And many human studies, such as PIMA Indian sibling analysis, clearly show that intrauterine exposure to maternal diabetes leads to long-term metabolic consequences of offspring, independent of genetics. And additional data complementing these findings, animal models provide mechanistic insights showing that intrauterine exposure to hyperglycemia leads to structural changes in hypothalamus, hippocampus, and leads to obesity and cognitive impairment. as a conclusion, I can say maternal glycemic milieu malprograms both metabolic and neurodevelopmental outcomes across generations and generations. That is one of the most possible explanation how the first 9 months shape the rest of your life. What is the most alarming is the perpetuation of a vicious intergenerational cycle of metabolic disorders, from insulin resistance to obesity and diabetes, rooted in intrauterine exposure. As I mentioned, maternal hyperglycemia and fetal hyperinsulinemia plays pivotal roles. However, focusing only a glycocentric perspective while disregarding the broader macro and micronutrient milieu would provide an incomplete understanding of the condition. Let's look at the side effect of fetal hyperinsulinemia, maternal hyperglycemia, plus macro and micronutrients milieu on the fetus, on the neonate, and on the offspring. Pay attention, please. Hyperglycemia is one of the major teratogens for the fetus. Therefore, exposure to hyperglycemia during the first trimester results in either stillbirth or congenital malformations. Fortunately, we don't see hyperglycemia during the first trimester in gestational diabetes. We usually deal with other complications, such as large gestational age, or macrosomia, or the increased obesity. And, of course, gestational diabetes has a wide range of detrimental effect on the mother, from spontaneous abortion to postpartum hemorrhagia. And the critical point is increased overt diabetes. The risk of overt diabetes 10 times higher after the 10 years, after the index pregnancy, 10 years after the index pregnancy. Not 2 times, not 3 times, full 10 times higher just in 10 years after the index pregnancy. And these ladies have double risk in terms of prediabetes. How prevalent such a serious disease? It affects the mother, the fetus, and the offspring. It's not easy to estimate the full picture, because full picture of epidemiology of gestational diabetes, because lack of internationally accepted diagnostic criteria. However, many studies show that the prevalence is widely different from countries to countries, ranging from 5% to 30%, depending on the diagnostic criteria used, demographic of the population, and the prevalence of risk factors. Who is at risk for gestational diabetes? As I mentioned before, gestational diabetes is exactly same with type 2 diabetes. So the risk factors also exactly same in terms of the core defect, insulin resistance and beta cell dysfunction. Being obese or overweight is this most important risk factor for development of gestational diabetes. Another risk factors include advanced age, family history of type 2 diabetes, previous history of gestational diabetes, genetic risk factors such as transcription factor 7 like 2, and polycystic ovarian syndrome. How can we, let's move on to diagnosis. How can we diagnose gestational diabetes? We have two commonly used approaches. One of them, one-step approach, the next one, two-step approach. Let's start with two-step approach. The initial step for two-step approach is 50-gram OGTT test called glucose challenge test. The purpose of the glucose challenge test is to identify individuals at high risk for GDM. It doesn't require fasting. That's the beauty of this test. It is given at 24 to 28 weeks of gestation. If first our glucose level equal or more 130 or 140, proceed to step 2. As you can see here, there is a little bit difference regarding the sensitivity between the 130 and 140. Then you can choose either of them. And the second step for two-step approach is 3-hour, 100-gram OGTT, oral glucose tolerance test. These tests have been used since 1964. The original O'Sullivan and Mahan criteria were slightly changed based on the method of blood analysis. Now, we are currently using Carpenter-Coston criteria because we use glucose oxidase method in the plasma. And for the diagnosis, 2 or more of the glucose values must be met or exceeded. I would like to emphasize this critical point. These original O'Sullivan and Mahan criteria were developed to identify women who are at risk for high risk development of overt type 2 diabetes. It was not created to identify perinatal outcome. To identify perinatal outcome, HAPOS study was conducted. HAPOS study is a most important groundbreaking study investigating the effect of maternal blood sugar levels on fetal outcome. Therefore, its results played a key role in shaping the criteria for one-step diagnostic test. HAPOS study is really huge study. Includes more than 25,000 pregnant women at 15 centers in 9 different countries, underwent 75-gram OGTT at between 24 and 32 weeks of gestation. It has some primary and secondary outcomes. The primary outcomes include high birth rate, primary cesarean delivery, neonatal hypoglycemia, and high cord blood serum C-peptide level. And all participants in HAPOS study were divided 7 different glucose categories according to their OGTT results. Category 1 represents the lowest category. On the other hand, category 7 represents the highest glucose category. And what is the result? It's very impressive result. This figure shows that the frequency of primary outcome across 7 different glucose categories. Here, figure A, look, as glucose category increase, the frequency of adverse outcome increases dramatically. In category 1, which represents the lowest level, what is the frequency of high birth rate risk? Only 5%. How about the category 7? Approximately 30%. The risk of high birth rate increases approximately 600% in category 7 compared to category 1. And as you can see in another primary outcome, this trend persisted across all other primary outcomes. And after this study, this groundbreaking landmark trial, International Association of Diabetes and Pregnancy Study Group endorsed new diagnostic criteria. According to these criteria, a diagnosis of GDM is made when 1 or more values meet or exceeded the threshold. Be careful. Even this threshold, the risk, perinatal outcome risk, increases approximately 75%. And now we have 2 different diagnostic criteria. In the one hand, 1-step approach, in the other hand, 2-step approach. Which one is better? This pragmatic randomized clinical trial of gestational diabetes evaluated this question, comparing 1-step approach to 2-step approach. This is really big study, including 23,000 women. And in the first arm, used 2-step approach, and second arm used 1-step approach. And primary outcome, they include 5 different outcomes in the primary, as a primary outcome. One of them, prevalence of gestational diabetes, large gestational age, perinatal outcome, preeclampsia, primary cesarean section. What is the result? As you can see here, as expected, the prevalence of gestational diabetes risk double in the 1-step approach compared to 2-step approach. Why? Because of the lower threshold and the need only one criterion to be made. But this study found no significant differences in perinatal outcomes between 1-step and 2-step screening methods. Therefore, you can choose either option. Another critical question is, can we reduce the perinatal outcome with treatment? This question were evaluated by 2 different studies. On the right, maternal fetal medicine unit study. On the left, Australian carbohydrate intolerance study. As you can see here, their diagnostic criteria completely different from each other, because Australian study used former WHO criteria, and maternal fetal medicine unit study used less glycemic level participants, and because they use Carpenter-Couston criteria. What is the result? The diagnostic criteria in the two randomized clinical trials were markedly different. However, outcomes were quite similar in both studies. These provide strong evidence that managing GDM can effectively reduce outcomes. And in a recent meta-analysis done by US Preventive Services Task Force, also similarly confirmed the result. It says the beneficial effect of the treatment is statistically significant. All this evidence dictates the necessity of properly managing women with GDM. So how can we properly manage gestational diabetic women? In any disease, understanding what is normal is essential before defining treatment goals to ensure proper management. Traditionally, glucose levels have become the key player for monitoring and directing treatment during pregnancy. So, what is the glycemic norms in normal pregnancy? These questions were evaluated by two different studies done by Paretti and Yogev. According to this study, glycemic norms in normal pregnancy are approximately 25% lower than the pre-pregnancy period. Why? The answer is obvious. Because of extremely high fetal glucose consumption. And look at the Yogev study result. Fasting 75, first hour after meal 105. HAPO study, look at the HAPO study's first category, the lowest perinatal outcome category. Exactly this numerically same number, fasting less than 75, first hour 105, and second hour less than 90. And how about the ADA's target? Glycemic targets set by the ADA are significantly higher than the physiologically low glucose levels seen in normal pregnancy. For fasting, less than 95, first hour less than 140, second hour less than 120. And regarding fasting glucose levels, as shown in the graph, all recommended levels are within the upper normal range. How about the first hour? For the 1 hour postprandial target, the recommended level exceeds the upper normal range entirely. And the 2 hour postprandial target is at the uppermost threshold of normal, 120. So given the two standard deviation of encompass approximately 90% of population, the ADA's target for gestational diabetic patients exactly out of the normal range. keeping this in mind, let's move on to treatment of gestational diabetes. Our primary goals is to maintain normoglycemia and prevent excess fetal growth and to avoid perinatal complications. We have two main approaches as a lifestyle intervention, including medical nutrition therapy and exercise. Medical nutrition therapy is the cornerstone of the management and first-line therapy and most effective therapy because it achieves glycemic control in more than 80% of women, and it reduces need for pharmacotherapy. But it requires multidisciplinary collaboration with clinicians, dietitians, and patients to ensure safe and favorable outcomes. And of course, diet and exercise should go in harmony, complementing each other for optimal results. Recommendation same as suggested in type 2 diabetes. 150 minutes per week, moderate intensity exercise. And to see the effect of medical nutrition therapy, all women are advised to self-monitor blood glucose levels before and 1 to 2 hours after main meals daily. If targets are achieved within 2 weeks, the frequency can be reduced. Of course, CGMS became more popular at the moment, and in certain cases we can use CGMS. If medical nutrition therapy fails, the next step is starting pharmacotherapy. The critical question, what time is the right time to start pharmacotherapy in gestational diabetes? We have 3 key reference points to start pharmacotherapy. Number one, gestational weeks. Number 2, ultrasound-based fetal growth assessment. Number 3, glucose measurements. If glucose target not achieved within 2 weeks, we should initiate pharmacotherapy. And if diagnosis is made over 30 weeks of gestation, we don't have time to regulate the glucose, and we have to initiate pharmacotherapy in these patients. And of course, the other key reference point is ultrasound-based fetal growth assessment. If abdominal circumference more than 75%, we can start the pharmacotherapy. And I would like to emphasize this critical point before moving on to pharmacotherapy. The fundamental principle of medication use during pregnancy. We have to answer 2 critical questions. Number 1, does the medication cross the placenta? If it doesn't, there is no concern about that. If this happens, does the therapeutic, number 2, does the therapeutic dose administered to the mother pose any harm to the fetus? And which drug or which medication meet these criteria? The answer is obvious: insulin. Because insulin now it's the cornerstone of therapy in gestational diabetes because of its efficacy and its safety. That's the reason it preferred agent across all major international guidelines. But as you know, it has some practical challenge with using insulin in gestational diabetes. It requires time, it requires training, more effort, more time, more cost, and more patient contact to adjust the insulin dose, and more hypoglycemia risk and more monitoring needs. Because of this issue, oral agents were evaluated using in gestational diabetes. And following a landmark study done by Audit Langer in 2000, glyburide rapidly became the most widely prescribed oral agent in US because it was shown to be as effective as insulin for glycemic targets. However, subsequent large-scale studies done by more sensitive assay clearly show that glyburide crosses the placenta and its associated higher rates of neonatal hypoglycemia, microsomia, and birth complication. And current international guidelines after this subsequent large studies, all international guidelines, including ADA, including FIGO, ACOG, recommended as the first line, recommended insulin as the first line therapy in gestational diabetic patients. And metformin, it remains a subject of ongoing debate in gestational diabetic women because of its transplacental transfer and uncertain long-term offspring effect. It has some beneficial effect. Of course, it improves glycemic control and reduces gestational weight gain. But even using metformin, approximately 50% of women require additional insulin therapy. And let's move on to postpartum management. You can imagine the delivery as a bariatric surgery. You know, after the bariatric surgery, insulin resistance disappears immediately. We see same thing in gestational diabetes. After the delivery, insulin resistance disappears immediately, and we stop all medication. And first 74 hours, we usually suggest self-monitoring blood glucose check to exclude persistent hyperglycemia. If it's persist, which approximately less than 5% of patients, we see this persistency, we need to initiate pharmacotherapy if necessary and lifestyle intervention, of course. If it doesn't persist, we continue lifestyle intervention lifelong. And for this patient, need lifelong glycemic screening, 1 to 3 years, based on their risk factors. And I know everyone is exhausted from this long gestational diabetes journey. This is the last slide. In conclusion, given its growing prevalence and intergenerational metabolic implications, the prevention of gestational diabetes is of paramount importance for public health and clinical practice. Pay attention, please. Not timely diagnosis, not treatment. The prevention of gestational diabetes is of paramount importance. And when the prevention is not achievable, timely diagnosis and appropriate management become crucial, as they remain the only effective strategy to break the intergenerational vicious cycle of metabolic disease. Thank you very much. If